Good afternoon, everybody. Today's lecture is by Dr. Matthew Peter Dattwyler. He is an assistant professor in the Department of Diagnostic Radiology and Nuclear Medicine at the University of Maryland School of Medicine, where he also serves as the Trauma Fellowship Director. Dr. Dattwyler completed his undergraduate education with a BA in history at Dartmouth College, followed by a postgraduate program at Harvard Extension School. He earned his medical degree from New York Medical College in 2010. He subsequently completed postgraduate training, which includes an internship in internal medicine um, at Mount Auburn Hospital, a diagnostic radiology residency at the University of Massachusetts, and a fellowship in emergency radiology at a Mass General Hospital. Dr. Dattwyler is a board certified uh, in American Board of Radiology. Clinically, Dr. Dattwyler specializes in emergency and trauma radiology. He provides imaging expertise in acute care settings. In his academic role, he is involved in training radiology residents and fellows and directs the Trauma Imaging Fellowship Program. His academic interests include emergency and trauma imaging, as reflected in his publications and radiology conferences, including the talk today. Thank you so much.
Thank you. All right, we'll get started. Today I'm going to be talking about blunt injuries of the bowel and mesentery. The learning objectives, we're going to try to identify CT findings of blunt bowel and mesenteric injury that mandate operative treatment, identify direct and indirect signs of CT imaging that require close clinical observation and reassessment, and identify injury mechanisms and associated soft tissue and bony injury patterns that increase the likelihood of blunt bowel and mesenteric injuries. And then also understand the CT imaging protocols and follow-up. So as far as an outline, we're going to briefly go over the background of blunt bowel and mesenteric injuries, try to understand the role of the radiologist, then go over, sorry, this should be reversed, go over the CT signs of blunt bowel and mesenteric injury. Then we'll look at the soft tissue and bony injuries. And then finally, just a few representative cases to sort of put everything together. So why are these injuries of particular importance? Blunt bowel and mesenteric injuries are not very common. There was a large paper put out by the East Society in the Journal of Trauma in 2003 that showed that only about 1% of blunt trauma patients presented with blunt bowel and mesenteric injury. That number can go up to about 5% if you include or if you select for more severe injury mechanisms. But it's important because CT findings are not that specific. And a lot of these they're missed by the radiologist, or they can be subtle enough where no findings are seen. So they're important in that way. Delayed in diagnosis of these injuries has been shown to significantly increase morbidity and mortality. And with the current surgical standard of care shifting away from operative management of solid visceral organs, it's really reliant on us as radiologists to identify these findings and push the surgeons towards laparotomy and laparoscopy. So why are these injuries missed? The clinical exam in the acute setting is often unreliable. We think classically of these patients presenting with peritonitis, but peritonitis is often a delayed finding. A lot of these polytrauma patients come in with other injuries that can distract, decrease consciousness from traumatic brain injury or intoxication, distracting injuries, and the like. There's a low incidence of these injuries, as I've already stated. So radiologists just don't have as much comfort or awareness of these of these injury patterns. And like I said, the findings can be nonspecific. So there's not much we can do about any of these except limited awareness. So hopefully today we can gain some awareness of these injury patterns and CT findings. So what's our role as radiologists? The surgeons rely on us for risk stratification rather than absolute certainty. We're helping guide their management, but we're not the end-all be-all. We play a key role in triaging patients into different management pathways. And just be aware that as recently as 2016, a paper found that up to 9.1% of patients with surgically proven bowel injuries had no abnormal findings on CT. So just remember that CT is not a rule-out test. We're not telling surgeons that there is no bowel injury. We're just providing them with another data point. So this is going through sort of how the surgeons and we at Shock Trauma think of our blunt trauma patients. They're first divided into hemodynamically stable and unstable patients. Those that are unstable may get fast exam, and if positive, will be brought to surgery. For the hemodynamically stable patients, we bin them. Well, they all go to CT, and then we try to triage them. We look for direct CT signs of definitive surgical bowel and mesenteric injuries, and those patients will likewise go to surgery. Of the patients who do not have definitive injuries, we sort of go down two pathways. One is there is evidence of bowel or mesenteric injury, but not meeting the strict criteria to mandate surgery. And those patients get shunted to close clinical observation. Their labs are trended, and there's evidence for early repeat CT being of utility. We recommend a low threshold for intervention in these patients. And then those patients who clearly have no signs of bowel or mesenteric injury, and they're still observed. Remember, CT is not a rule-out test, even in the absence of clinical imaging signs. So those patients are still observed, just less frequently. We don't mandate follow-up CT, and they're sort of shunted towards discharge if possible. For the close observation group, they'll go one of two ways. They'll either develop peritonitis or worsening abdominal pain or refractory shock, things like that would clinically shunt them to surgery, or they'll improve over time and could be potentially discharged. And then we'll talk about the role of repeat CT. So our protocol at Shock Trauma Hospital, we give IV contrast, we do power injection, and we obtain imaging of the abdomen and pelvis in both the arterial and the portal venous phase. IV contrast is essential for the assessment of active bleeding of the mesentery and of bowel wall enhancement characteristics. We use multiplanar reformats, and we also acquire images in dual energy. Talk about some of the ways we can utilize that later. We do not use oral contrast. So the use of oral contrast, we find it prolongs door to scan time. You have to prep the patient. Oftentimes in these patients, the contrast doesn't even get far enough to be relevant on the exam. It can obscure bowel wall perfusion abnormalities, and it represents an aspiration risk. And most importantly, in a 2013 article, Lee et al. Demonstrated non-inferiority of scans without oral contrast by meta-analysis in the detection of surgically important lesions. So we talked about the role of, or the potential need for re-imaging patients who are under close observation, who haven't met the criteria for surgical bowel lesion. And it's important because these injuries may evolve over time. Patients may present too early to exhibit signs of bowel ischemia on CT. Injured mesenteric vessels may be in spasm. Remember, these are smaller terminal vessels. They spasm, so they don't necessarily bleed on our initial CT scan. And small perforations of the bowel may be beyond the resolution of CT, but over time they'll continue to weep fluid and may declare themselves. Recent surgical literature suggests that delay in diagnosis of 5 to 8 hours leads to significant increases in morbidity and mortality from uncontrolled hemorrhage and sepsis related to spillage of bowel contents. And so at our institution, our recommendations in patients who have signs of mesenteric and bowel injury that don't require immediate surgery is for serial abdominal exams, followed by a CT at 4 to 6 hours. This is the paper, the main paper in support of early scheduled CT. They didn't go quite so early as us. That's not the 4 to 6 hour range. This was within 48 hours. But they found that they had better detection of injuries needing surgery and greater, it allowed them greater safety in managing patients non-operatively. Here you can see they used the Fage CT score, looking at the initial CT followed by the repeat CT, and found that the sensitivity of that score increased the negative predictive value and the area under the curve. So they found that repeat CT improves diagnostic accuracy and increases confidence in managing these patients with non-operative management. Just to briefly touch on the Fage scoring system, we don't routinely use it at our institution, but it's something to be aware of. It has been validated, and it can be of usefulness in equivocal cases. I'm just introducing it now, and we'll go over it in more detail later after we've gone over some of the CT findings. All right, so how are these patients injured? We'll look at a little bit of epidemiology and mechanisms of injury for these bowel and mesenteric injury patients. They are most commonly associated with high energy blunt trauma. At our institution, and I think at most institutions in the United States, motor vehicle collision accounts for the majority of cases. Other mechanisms are pedestrian struck by motor vehicle, bicycle and motorcycle accidents, fall from heights, and assaults. Occasionally we have someone's trod on by a horse or something like that. But far and away, motor vehicle collisions are the most common for this type of presentation. There are 3 main injury mechanisms that are thought to injure the bowel in blunt trauma. The first is crush injury. This is a direct mechanical compression of the bowel, usually between the abdominal wall and the lumbar spine or the pelvis. It results in crushing, tearing, and devitalizing of bowel wall and mesenteric tissues. And the crushing force is applied by an external object, usually a seatbelt, but it can also be the steering wheel, handlebars of a bicycle, someone's fist, things like that. Burst injury is also the result of extrinsic compression. This is an indirect injury where a sudden increase in intra-abdominal pressure causes focal bursting of fluid-filled bowel loops. It occurs at pressures around 120 to 140 millimeters of mercury which is, I'm told, relatively low. And so these patients can present without a lot of obvious external signs of trauma. Finally, there's shear injury. This is rapid deceleration that results in stretching of the bowel and tearing of either the bowel wall or the interface of the bowel and the mesentery, a so-called bucket handle tear. And we'll go over sites where this is most common and where we should focus our scanning on CT. So the shear injuries stereotypically take place at sites of transition of the bowel from relative fixation to relative mobility. And most commonly, these are seen at the ligament of Treitz, where the jejunum becomes mobile from the retroperitoneal duodenum, near the ileocecal valve, where the terminal ileum, distal and terminal ileum, are mobile relative to the ascending colon, and then the sigmoid colon, which is fixed proximally at the descending colon and distally at the rectum. So these are the common areas where we see these deceleration type or shear type injuries. So that's the mechanism. What are the injury patterns that the surgeons see? First is bowel mural hematoma. This usually occurs in the submucosal layer. There are deserosalization injuries, which are not technically surgical, just tearing of the outer layer of the bowel. Partial thickness injuries involving layers deep to the serosa, but not through to the mucosa, and then full thickness injuries involving all layers. And then ischemia, which is usually a disruption of the mesenteric vessels. Patterns of mesenteric injuries, we see hematoma. We see laceration, either with or without active bleeding. And then we see avulsion. So avulsion takes place at the interface between the mesentery and the bowel. Surgeons refer to this as a bucket handle tear. And as you can imagine, it results in segmental ischemia of the bowel. All right, now we're going to talk about some of the CT signs. So what we'll see at imaging. There are quite a few CT signs of bowel and mesenteric injury with a wide reported range of sensitivities and specificities. The important thing to remember is that there are few CT signs that definitively require emergent surgery, but they're all rather insensitive. And so mainly when we're making this diagnosis, we're dealing with a collection of sensitive but rather nonspecific signs. So for the very specific signs of surgically relevant bowel injury, we have bowel wall discontinuity, pneumoperitoneum, which is only definitive in the setting of blunt trauma, not penetrating trauma, and extraluminal oral or rectal contrast. Some of the more sensitive but nonspecific signs will be bowel wall thickening, abnormal bowel wall enhancement, free peritoneal fluid or hemoperitoneum, and mesenteric or interloop fluid. For the mesenteric injuries, active IV contrast extravasation is an indication for emergent surgery. And more recently, it's been recognized that segmental bowel non-enhancement or hypoenhancement is also a surgical lesion, indicating bowel that's at risk for becoming necrotic due to mesenteric avulsion. On the non-surgical side or non-specific side will be mesenteric vessel beading or cutoff, non-bleeding mesenteric hematoma, and mesenteric stranding. All right, so now we're just going to go over each one of these signs in detail. So bowel wall discontinuity. This is direct CT evidence of traumatic perforation of the bowel, either by crush or burst mechanism. Commonly seen in conjunction with wall thickening and interloop fluid. It has 100% specificity, but is highly insensitive at only 5 to 10%. And even when present, it can escape prospective detection. Here might be hard to see, but this C-shaped loop is not a curved bowel loop. It is a continuous bowel loop with an open defect on one side. Pneumoperitoneum and pneumoretroperitoneum has a somewhat higher sensitivity. It's reported with a non 100% specificity because some people have found isolated pneumoperitoneum in the setting of pneumothorax and also with intraperitoneal bladder rupture and Foley catheter placement. But in actuality, the specificity is almost 100% in the setting of abdominal wall contusions related to seatbelt signs and in conjunction with other soft signs of bowel injury. So we treat it as 100% specific for bowel injury. Remember to use lung windows in your search pattern. Makes the conspicuity of small foci of gas much easier to detect. And focal mesenteric pneumoperitoneum is helpful to identify the site of perforation. One thing I found that can fake out residents early on is so-called Macklin effect. This is where rapid compression of the chest in the setting of blunt trauma causes peripheral alveolar rupture and air escapes and tracks along bronchovascular bundles. And we see it collecting in the mediastinum and in the extrapleural space and extraperitoneal space. So we can see it here associated with this rib seemingly above the liver. But this is actually in the extrapleural space rather than in intraperitoneal. Extraluminal oral or rectal contrast. This is 100% specific. It's rather insensitive, but at this point, it's clinically irrelevant. As I said before, oral and rectal contrast are no longer routinely administered for blunt trauma scans. It can be seen on follow-up scans. Sometimes we do give oral contrast on our delayed scans, especially in the setting of suspected duodenal injuries. Free peritoneal fluid. So now we're moving outside of the realm of specific surgery mandating CT signs and into the more sensitive signs. So the sign with the highest sensitivity, although not perfect, is free peritoneal fluid. It can be physiologic in both men and women. Unfortunately, even small amounts can also be a sign of occult bowel injury. So patients with free fluid are oftentimes brought for observation, even when we're fairly sure the fluid is physiologic. So make sure to check all the peritoneal recesses, the subphrenic spaces, the hepatorenal recess, the paracolic gutters, and the deep pelvis. Especially with bowel and mesenteric injuries, the fluid doesn't necessarily settle down into the deep pelvis right away. It can layer more superiorly if that's where the injury is located. A little bit about free peritoneal fluid. The teaching used to be that a small amount of fluid in the pelvis in a woman could be physiologic, but never in a male. There have been a number of papers since then that have shown that that's not the case, that small amounts of fluid in men can be physiologic. So a paper by Drazen et al. Evaluated men with blunt trauma and found that isolated free fluid in trace volumes may have no clinical significance. You et al. Found the same and found that if the fluid was below the level of S3 and located just within the pelvis, again, likely of no clinical significance. Again, this has to be simple fluid in men. So small amounts of fluid can be physiologic when appropriate mechanism, especially in the absence of solid organ injury. We still have to suspect that there is an occult bowel injury. So these are patients who will still get close clinical observation and may get a follow-up CT. We're more suspicious anytime it's greater than a trace volume, anytime it's external to the pelvis, non-simple attenuation, and in the setting of abdominal wall contusions or injuries. And unfortunately, it's not sensitive enough for us to use as a rule-out test. So we cannot, the absence of fluid does not allow us to exclude significant blunt bowel or mesenteric injuries. There are other causes of simple attenuation free fluid, so always be on the lookout. If you see it, it can be a sign of small bowel perforation, succus, small bowel contents. We see it with intraperitoneal bladder ruptures representing urine, with gallbladder lacerations representing bile, and then in a simple ascites in patients with underlying liver disease. Much more, or more specific, I'll say, not to the level of requiring surgery, but mesenteric or interloop fluid. We see this as fluid trapped between the leaves of the mesentery. So on CT, this is fluid that is in between small loops of bowel, or has a triangular or polygonal configuration. So this lets us know this fluid is not free peritoneal fluid, but instead trapped within the leaves of the mesentery. And it's much more indicative of a bowel pathology than just free fluid. It's an indirect sign of bowel and mesenteric injury, but with greater specificity for surgically important injury than pure free fluid. And it has further increased specificity when paired with bowel wall thickening and abnormal bowel wall enhancement. It can be useful, I find it useful, in identifying subtle small bowel perforations. So I'm very careful to inspect any loops of bowel around these small collections of fluid. Next, we'll talk about abnormal bowel wall enhancement. There is hyperenhancement, which I find is not usually indicative of a surgically important lesion. If anything, it's reactive hyperemia due to a contusion or compression, but it can point you towards areas of true injury. And those true injuries are usually the hypoenhancing segments. So the hyperenhancing segments can be used as a juxtaposition. The hypoenhancing or heterogeneously hypoenhancing segments are divided into focal, segmental, and diffuse processes. Focal usually represents bowel contusion, small perforations, or focal ischemia due to small rents in the mesentery. Segmental, which we'll talk about separately under the mesentery section, is now a very specific sign of devascularization due to mesenteric avulsion. And the diffuse bowel processes, whether they're hypoenhancement or hyperenhancement, are usually only obliquely related to trauma and represent either hypoperfusion complex in patients with shock, or are a CT timing issue or related to low cardiac output. So here we're going to look at some abnormal bowel enhancement. So we scroll through, we see some triangular collections of mesenteric fluid, some interloop fluid, and then if we zoom in, it's a very subtle finding. Probably shows up a little bit better on the PACS workstation, but very easy to walk by these focal areas of bowel hypoenhancement. And so this is where the mesenteric fluid and interloop fluid is very useful in drawing our eye in to finding these areas that are suspicious. It has a reported specificity of 90%. But like I said, it's very subjective and includes both surgical and non-surgical lesions. So not very discriminatory. It has a low sensitivity. Focal hypoenhancement is often the sign of bowel contusion, whereas focal patchy mixed enhancement may indicate small areas of perforation, especially in the setting of interloop fluid and abnormal thickening. Hyperenhancement is nonspecific, and usually we see it in the setting of shock bowel. Bowel wall thickening. Since we don't routinely give oral contrast anymore, bowel wall thickening is a little hard to judge. It must be on either fluid or gas distended bowel. We need to see a thickness of greater than 3 millimeters of the small bowel and large bowel thickness of greater than 5 millimeters. Despite reported high sensitivity for injury, focal thickening is often a sign of bowel contusion and mural hematoma and is not a surgical lesion. It doesn't represent a perforation. Associated abnormal mural enhancement helps contextualize this finding, and diffuse wall thickening, like abnormal hyperenhancement, is often a sign of hyperperfusion complex. Here's an example of both thick and hyperenhancing bowel that's diffuse. So this is not a sign of bowel injury. Here we have hemoperitoneum from a large liver laceration and other signs of hypoperfusion complex, such as interstitial pancreatic edema and gallbladder wall edema, periportal edema, things like that. CT signs of mesenteric injury, again, starting with those that require emergent surgery. Active mesenteric contrast extravasation, as you can see here in the right lower quadrant, is 100% specific for mesenteric injury. It has a very low specificity, likely due to small vessel caliber and vasospasm in the acute setting. Surgical repair is required due to lack of uncontained bleeding and from lack of tamponade effect and the risk for developing bowel ischemia. Something that wasn't recognized early on in the literature of bowel injuries, but it has since been, is the segmental hypo and non-enhancement of bowel. It's associated with mesenteric bucket handle tears and bowel ischemia. We see segmental hypoenhancement of the bowel. Segmental hypoenhancement of the bowel and abdominal wall injury on CT were independent predictors of injury and regression analysis. And overall CT sensitivity in detecting ischemic mesenteric laceration was okay, but specificity was quite high. at around 95%. So this sign requires visualization of transition from normal or hyperenhancing bowel to non-enhancing bowel and then back again. So it's not enough just to compare one loop of bowel on this side of the abdomen to another loop of bowel on the other side. You really have to trace the bowel, and you'll see these very well demarcated transition points, followed by in this case, a long segment of non-enhancing bowel. And then this loop comes back up, and we see another very well demarcated line of transition from non-enhancing bowel back to enhancing bowel. And I find that this is near pathognomonic for mesenteric rents or bucket handle tears that require surgical treatment. This is an intraoperative photo that was given to me by one of the trauma surgery fellows. If you look closely, you can see this large mesenteric defect, and then areas of dusky, non-perfused bowel that was supplied by the vessels in that mesentery, juxtaposed with more normal appearing bowel more proximally. This slide shows progression of a bucket handle tear. So on admission, it was not appreciated that this patient had a segment of bowel that was non-enhancing. The hemoperitoneum was due or thought to be due to splenic injury, which is not shown. They were re-imaged on day 3 to follow up the splenic injury, and again, the bowel non-enhancement went undetected. And then finally on day 6, patient developed leukocytosis and metabolic acidosis and was re-imaged for that reason. And on this day, you can see the frankly necrotic bowel with pneumatosis. So from the University of Maryland, this study from Dr. Bozcek used logistic regression to identify 2 CT signs from a univariable analysis that were highly associated with ischemic mesenteric laceration. And the first and most important was that segmental bowel hypoenhancement with an odds ratio of 20 to 22. And so this is now recognized as another surgical, definitively surgical lesion. I mentioned earlier that we scan the abdomen in our blunt trauma patients in both the arterial and portal venous phase. If your institution does not do that or scans only in the portal venous phase, I offer this case as sort of a cautionary tale, and perhaps a reason why some of the earlier literature reports such a high rate of bowel injury or missed bowel injury with no CT findings. So this is the arterial phase. As the bowel transitions from the duodenum past the ligament of Treitz, you see, again, a well demarcated line of normal enhancing bowel transitioning to non-enhancing bowel or hypoenhancing bowel on the arterial phase, with pseudo-normalization on the portal venous phase. So there's definitely delayed filling of this. So the bowel is not completely ischemic at this phase, but it does demonstrate delayed enhancement. If your institution has dual energy capabilities, you can also use iodine maps or low KEV virtual monoenergetic images, and these have been shown to increase conspicuity of these hypoperfused and non-perfused bowel segments, as you can see here. Finally, for rounding out the mesenteric injuries that are more specific, more sensitive than specific, we have mesenteric stranding, mesenteric blood without mass effect. It's less specific for mesenteric hematoma, for mesenteric injury than focal hematoma, and it's treated conservatively in the absence of other findings. Non-bleeding mesenteric hematoma, as we see here in the ileocolic mesentery, is blood with mass effect. Like mesenteric stranding, it's a sensitive sign for mesenteric injury, but not specific for a surgically important lesion. This is also treated conservatively unless there are signs of bowel ischemia or a preponderance of other soft signs that would warrant surgical exploration. Mesenteric beading or cutoff is a mild form of mesenteric vascular injury than active bleeding. I find it's a relatively subtle sign that depends on high quality CTA images. So I don't often appreciate this on our scans. Again, these are treated conservatively unless there's associated segmental bowel hypoenhancement indicating a bucket handle tear. In this case, there actually is decreased enhancement in a segmental way. So this was a surgically relevant lesion. So the CT sign summary. Hopefully you've seen some cases of CT signs of blunt bowel and mesenteric injury that mandate surgical intervention. Understand that they're rarely seen, and so oftentimes only sensitive findings of blunt bowel or mesenteric injury are present, and determination for surgery must be made in the context of those signs in consultation with the trauma surgeon and evaluation of the patient's clinical and laboratory picture. There are CT scoring systems which can provide guidance in equivocal cases, and patients should undergo early scheduled repeat CT if they have signs of injury but do not require urgent surgery. So I've found in my practice that the mesenteric bucket handles are probably the most common finding requiring surgery that I encounter. Very rarely do I encounter open perforations or active mesenteric bleeding. Pneumoperitoneum would be a close second to the mesenteric bucket handle tears. But I have noticed that there are sort of imaging constellations or clusters of these soft signs of bowel injury that I find are likely more correlated with surgically important lesions. And I bring these to the attention of the surgeons. So one of those clusters would be focal bowel wall thickening with heterogeneous or hypoenhancement and interloop fluid. So I would recommend in your search pattern to have your eye drawn to those areas of interloop and mesenteric fluid, and then really scour the bowel for focal thickening, hypoenhancement. And I find that those can really help in the identification of small perforations. Crush injuries with mesenteric rents. These are small focal tears of the mesentery off the bowel. These are usually seen in the setting of abdominal wall injuries, which we'll go over shortly. Seen with mesenteric stranding or hematoma, and small or moderate volumes of hemoperitoneum. So those would be another thing that I would argue more towards surgical management. And we've already gone over this last one, which is now, in my mind, clearly moved into the realm of surgically relevant lesions or surgically requiring lesions. The segmental bowel hypoenhancement in the setting of mesenteric vessel beading and mesenteric stranding. When it's really equivocal and you're not sure what to do, you can fall back on CT scoring systems such as Faget. He gives a score 1 to 5 for all the, or for many of the signs, and it's additive. And in this validated study, they look at a score of 5 or above being used to triage patients to surgery. As you see, mesenteric pneumoperitoneum and bowel wall discontinuity are automatic 5s. That makes sense. And the rest require several nonspecific findings together to prompt surgery. Just to highlight that in the scoring system, they also recognize abdominal wall injuries as clinically relevant to the diagnosis of blunt bowel and mesenteric injuries. So with that being said, let's look at some of the soft tissue and bony injury patterns that really elevate our suspicion that these patients have blunt bowel and mesenteric injuries. So like I said, the majority of our patients who come to us with these types of injuries are within a motor vehicle at high speed. Many of them are restrained. And so there's a type of injury pattern called seatbelt syndrome. It can result in chance fractures, seatbelt contusions, traumatic lumbar hernias, and abdominal wall tears. And these are all, to varying degrees, strongly associated with bowel or mesenteric injury. We have the seatbelt sign, transverse contusion across the abdomen. We have a traumatic lumbar hernia, which is decompression of the retroperitoneum through the inferior lumbar triangle. Frank abdominal wall tears, which have a very high association with bowel and mesenteric injuries, and chance fractures, now referred to as flexion distraction type injuries. Just a quick montage of cases I've collected that have the seatbelt sign. You can see it on axial and coronal. They can be diffuse, they can be more focal. They can involve bony elements. So the main findings are subcutaneous fat stranding, skin thickening due to abrasion, subcutaneous hematoma. And it's important to note the relative position related to the level of the iliac spines, which we'll talk about in a bit. The clinicians have can see clinical seatbelt sign. The CT seatbelt sign is, I think, more sensitive. We'll be able to see injuries that are not visible to the clinicians. So this was an interesting paper I found that looked specifically at seatbelt signs and found that the addition of a CT seatbelt sign to a clinical seatbelt sign resulted in a roughly 4-fold increase in the need for surgery. And it also found that the positioning of the seatbelt sign relative to the anterior superior iliac spines was also correlated with increased need for surgery. So if you were wearing the lap belt incorrectly above the pelvis in an infraumbilical region, that is going to increase your risk for bowel and mesenteric injuries. Traumatic lumbar hernia, just a few representative cases. So this is a fascial weak point at the inferior lumbar triangle, at the aponeurosis of the internal oblique muscle as it blends with the thoracolumbar fascia of the paraspinal muscles. So here we see it on 3D anatomic rendering. It's next to the paraspinal muscles. It's along the iliac crest, and it's this aponeurosis of the internal oblique muscle. This is a weak point, not always due to seatbelt compression. It can be due to any sort of compression if the patient is unrestrained, thrown around the cabin of a vehicle. Any increase in abdominal pressure can cause this sort of injury. This 2014 study by Dr. Melnick et al. Looked at patients diagnosed with traumatic lumbar hernias. He found a non-statistically significant increase in the incidence of blunt bowel and mesenteric injury with left-sided hernias versus right-sided hernias, which he thought possibly was due to the relative fixation of the descending colon relative to the more variable position of the cecum in the ascending colon. He also found an increased risk for blunt bowel and mesenteric injury with defects greater than 4 centimeters, and for those hernias that contained bowel. Interestingly, the areas of injury could be remote from the hernia itself. Going back to that paper from Dr. Boschek, again, the segmental hypoenhancement of bowel was the most important finding on regression analysis for detection of ischemic mesenteric lacerations. But he also found that abdominal wall injury also led to an increased odds ratio of 5. Frank abdominal wall rupture. I see this not too infrequently. Few representative cases. So here, much like the traumatic lumbar hernia, you see disruption of the abdominal wall. This one, however, continues across much of the anterior abdomen as well. We have similar findings of subcutaneous fat stranding and abrasion as in the seatbelt sign, with the addition of severe thinning and tearing of the rectus muscles. Sometimes we don't appreciate the full severity of the injury because the rectus sheath remains present and intact. But here you can see normal rectus muscle tendinous intersections, retraction of the rectus muscle above and below the level of the disruption, and then that severe thinning of the anterior abdominal wall that represents just the layers of the rectus sheath that are present. And you can see the bowel herniating into that defect. So it's important to recognize that this patient has a very severe abdominal wall injury and is at massively increased risk for bowel and mesenteric injuries that require surgery. And then in the more severe forms, you can have rupture of that rectus sheath as well as disruption of the muscle with herniation of bowel. And then finally, we have flexion distraction or chance fractures, this so-called seatbelt fracture. The axis of rotation provided by the seatbelt pinned to the anterior abdominal wall results in severe compressive forces of the vertebral column and then distracting forces along the posterior tension band. The vertebral body component can consist of either a wedge compression fracture, a burst fracture, or these posterior corner avulsion fractures. In all of these, notice the intraspinous widening. In this case, there's a small avulsion fracture at the supraspinous ligament. In this case, it's purely ligamentous disruption of that posterior tension band. And then as we go out parasagittally, we have further disruption of that posterior tension band on the right, a fracture going through the pedicle in the base of the superior articular process, which disrupts this facet joint's integrity. And on the left, we see this somewhat subtle facet subluxation on the sagittal. And I find that if I'm evaluating these, it's often helpful to go to the coronal, where I find these facet subluxations and uncovering are much easier to appreciate. Here you can see a normal interfacet joint alignment, and here you see that slight widening and then uncovering on this side. And so those are all going to markedly increase your risk of bowel and mesenteric injury of surgical import. So I would encourage you all to really evaluate the bony and soft tissue components of these patients, in addition to really looking for those CT signs in the peritoneal space. I know that was a lot to throw at you. A lot of those CT signs, they don't really make sense in isolation, or there's nothing to unify them. So I just wanted to go over a few cases and just see if we can sort of put some of those together into context. So this was a patient with a high-speed motor vehicle collision. They were a restrained driver. When I'm going through these cases, the first thing I look for is the presence of a seatbelt sign. So I go on the axial and coronal, and I find this contusion here. It's just below the level of the umbilicus. You can see it here, and it's well above the iliac spines. So immediately my level of suspicion is high. In this case, they also have a very large traumatic lumbar hernia. It's left-sided. So again, that increases suspicion. It does not contain bowel. It contains pure fat. So not as much, but very suspicious. This is certainly not someone who would be triaged to the green pathway of simple observation. At the very least, they're going to get close clinical follow-up and follow-up CT. Moving on through the same patient, as we look intraperitoneal, we see interloop fluid. We see areas of bowel wall thickening, and we see a moderate amount of hemoperitoneum. So in isolation, any one of these signs is not very specific for injury. However, putting them all together, this is a very suspicious picture for a surgically relevant bowel injury. And it took a while, but scrolling through the axials, we were actually able to appreciate this prospectively. It's a little hard to capture in a single static image. But there is a full thickness distal jejunal transection. We're just scrolling through the bowel, and one loop of bowel just went nowhere, and the other one picked up. We couldn't get them to connect, and this was a frank jejunal transection. So it's difficult to see even in retrospect, but I would say putting together all those signs, the soft tissue body wall injury, intraloop fluid, moderate hemoperitoneum, and bowel wall thickening, all lead us to recommend surgical intervention. If we were to put this into the Faget scoring system, he would get a 3 for abundant hemoperitoneum, a 2 for bowel wall thickening, 2 for mesenteric stranding, and a 2 for abdominal wall injury. So he's at a 9, well above the 5 recommended for recommending surgery. Case 2, again, we have a seatbelt sign. It's rather faint on the coronal, a little more apparent on the axial. The abdominal wall musculature is intact. We have free fluid in multiple compartments, so not just the deep pelvis, but in the hepatorenal recess and the subphrenic space. Again, that's going to raise our suspicion further, especially in the context of a seatbelt sign and in the lack of solid organ injury. So already this patient would be someone to triage to close observation. Add to that, you have bowel wall thickening with intraloop fluid. And on closer examination, we have areas of focally decreased or heterogeneous enhancement of the bowel wall in association with that intraloop fluid. And while there was no direct evidence of a surgical bowel lesion, no pneumoperitoneum, no frank bowel wall discontinuity, we recommended surgery, and this patient was found to have a focal jejunal perforation. Finally, we have this case here on the 3D rendering. You can see the surgeon saw clinically depression along the chest with contusion and along the abdomen. Here we can see on the 3D that it's split the pec major muscle and injured the rectus muscle as well, also the oblique muscles. Here we see seatbelt sign infraumbilical, again above the level of the anterior superior iliac spines. We see a traumatic lumbar hernia on one side, and actually if we looked at the sagittal, there would be severe thinning of the rectus muscles from an anterior abdominal wall injury as well. Here, very classic, that's segmental non-enhancement. So we get reactive hyperemia of the bowel immediately going into the transition to this devascularized bowel. And so this was prospectively called as a mesenteric bucket handle tear. Also, the patient has a large volume of hemoperitoneum, which we can see in all his spaces. Just to round it out, they have a mesenteric hematoma, which is non-bleeding. They have cecal wall thickening, exuberant hemoperitoneum, and here again we see that non-enhancing ileal segment. So this was a case of direct evidence of a surgical bowel lesion with segmental non-enhancement of the ileum, and secondary findings that supported that diagnosis but were not needed to recommend surgery. So that's my time. Hopefully, this will allow you to identify those CT findings that warrant emergent surgery in patients with blunt bowel and mesenteric injury, to identify the indirect or non-specific signs of injury and those CT patterns that would either prompt you to recommend surgery or close clinical observation and reassessment. And then to identify soft tissue and bony injury patterns that should really increase your suspicion for blunt bowel and mesenteric injuries. And then understand the role of
of our CT protocols that we use to identify these injuries and the follow-up protocols that we use. That I thank you.